Thank you very much. I'm very grateful for the opportunity to speak today. We've heard a lot this morning about how genomics is set to become part of routine clinical practice, and there is a huge promise about making this part of routine healthcare. This is not a new ambition, and next week marks the 25th anniversary of the first announcement of the first survey of the human genome. And as part of that announcement, Bill Clinton said that sequencing the human genome will revolutionize the diagnosis, prevention, and treatment of most, if not all, human disease. And as we've heard already, to a great extent, if you're a patient with rare disease or a patient with cancer, your care has truly been revolutionized over the past 2 decades. And we've just heard beautifully about how increasingly we have therapeutic options for our patients now. But in mainstream healthcare, genomics for most people has very little to do with your day-to-day care. One of the areas that there is a huge excitement around that has broad applicability is this concept of pharmacogenomics. And we've heard a lot about that already this morning, and this is the area that I work in. And over the past few decades, the evidence base for pharmacogenomics has increased exponentially. There are now 573 gene-drug pairs with any prescribing evidence, and there are 28 of those where there are explicit pharmacogenomic prescribing guidelines. So if you see a patient and you know their genetic information, you can use that information to select the most appropriate medicine for them, a safe medicine and an effective medicine. This genetic variation is very common in the population, but also the medicines it's related to are incredibly commonly prescribed as well. Medicines like antidepressants, antiplatelets, and pain relief, and the cost of treating conditions related to these medicines are extremely large. These are figures taken from the NHS Business Service Authority in 2020-2021, and you can imagine even small improvements in the safety or effectiveness of these treatments could have significant health gains for a health system like the NHS. And I want to focus on a story just very briefly at the beginning around the use of pharmacogenomics to guide antiplatelet therapy. So clopidogrel, one of the most commonly used antiplatelets globally, is not an active medicine. It needs to be absorbed by the ABC1 transporter, and then it's converted in our livers into its active metabolite so it can inhibit platelet aggregation. And the enzyme CYP2C19 is the major player in that process. But we know that CYP2C19 is highly polymorphic, and there's a high frequency of loss of function variation. And a study that we undertook on an unselected cohort coming through our acute medical unit a couple of years ago found that approximately 30% of our admissions carried a loss of function variant. And work undertaken by colleagues at QMUL, led by Emma McGavin, has shown that in the genes and health cohort, in that Southeast Asian population, over 50% of people carry one of these variants. And that's clinically relevant. We know these variants predict decreased enzyme function, which from a pharmacokinetic perspective impair the metabolization of clopidogrel. That diminishes platelet inhibition, and from a clinical perspective, that increases your chance of having these secondary vascular events. So these individuals should not be prescribed clopidogrel. An alternative medicine should be used. And that evidence base, we've heard about the importance of NICE and regulatory authorities this morning. That led to a recommendation last summer that all patients who've had a stroke or TIA in this country should have pharmacogenetic testing. And that was informed in part by a health economic analysis, which suggested that the potential value to the NHS of this intervention was £454 million over a 5-year time horizon. That's based in the reduction of secondary strokes. It's based on the quality of life years gained from those individuals not having those debilitating secondary events. So for many gene repairs, the evidence base is there. And in theory, to realize the value of pharmacogenetics in routine clinical practice, the data needs to be used to guide prescribing. So we're very good at generating data, and we're through organizations like GEL, we're good at generating that data, and we're good at generating those insights. So we not only can produce that information, but we can also understand what we should potentially do with it. What we're potentially not quite as good at is using those insights and getting them into the hands of clinicians across the clinical setting and driving action, changing behavior on a system-wide level. To put that even more simply, We have lots of data that sits in laboratories and sits in data silos, but how do we get that into the clinical setting, outside of rare disease centres, outside of cancer centres, but into acute medical units, into A&E departments, into GPs and pharmacies? How do we make sure that data is available in a clinically relevant format and a clinically relevant time frame? And to do that, we think it's important to develop an end-to-end service. And what does an end-to-end service look like? Depending on your geography, depending on your clinical context, depending on what type of system you're working in, you're going to create this service in different ways. And we work with colleagues internationally who will design this in different ways. There's questions about how a clinician might order the test, how the test is performed, what technology you're going to use, what genes and variants you're going to focus on, and then critically how the results are returned and used. Are they within the electronic healthcare record system? Is it delivered via PDF? Do patients have access to their data? And so we had lots of choices to make around how do we design this service, but critically, it should not be people like me who get to decide how this is put together. We've heard this morning about the importance of co-curation of these types of initiatives, and so we were very keen to understand preferences of the users and stakeholders. And so healthcare organizations are very important, labs and tech providers are very important in designing a service like this, but critically it's the interaction of the patients and the healthcare professionals where we need to drive action. It's there that this genomic data is going to be used to choose the right medicine for a patient. And so you can have the best laboratory test in the world producing data with unparalleled accuracy, but unless you design a service that people can use and want to use, it just won't be used. And so we aimed over a large program of work to understand public and healthcare professional preferences for a pharmacogenetic testing service. And we did that in lots of different ways, through interviews, and we had a quantitative approach to that as well. From a health economic perspective, there's lots of ways that you can undertake what we call preference valuation. The tool that we decided to use was discrete choice experiments. And what that relies on is this concept of attribute-based assessments. And it's based on the understanding that when you make choices about anything in life, what product to buy in a shop, you're not making decisions based on those products as homogeneous entities, but you're making trade-offs by their relative attributes. And allow me for 1 second to explain what I mean through the medium of running shoes. So let's say that you are asked to choose between these two running shoes. You're not simply looking at them and making choices just based on them as that homogeneous entity. What you're doing is you're making trade-offs between the brand, whether they have a carbon plate in, and the cost of those. And that theory that people make trade-offs as part of everyday life, consciously or subconsciously, has been leveraged as part of by advertisers and by marketeers using discrete choice experimentation. And if you ask people, force people to make those choices at scale and iteratively, saying which one would you choose, which one would you choose, mathematically you can start to draw out the attributes and the levels which drive uptake of a service. We applied this to a pharmacogenomic testing service. There is a very set approach for how you undertake discrete choice experiments. We started with a choice question, and we did this for healthcare professionals and for patients. I'm going to talk about the patient work that we did here. We asked patients, if you had to choose one of these pharmacogenomic tests to guide your treatment, which would you choose? The attributes were based on extensive interviews, and we focused on the type of the test. So was it an invasive test or a non-invasive test? Was the data made available to the patient? Was the data available for longitudinal healthcare, or maybe just a snapshot at one moment in time, and the turnaround time? People were giving training material, they were showed videos, but this is what the survey looked like. And essentially, they were asked to choose, if you had to choose one of these, which one would you choose? Test A or Test B? If we were to show people every theoretical combination versus every theoretical combination, that would be over 6,500 questions, but mathematically, we were able to present people just 8 choice questions, and we recruited 2,000 participants to this piece of work. The outputs from a discrete choice experiment are incredibly boring. This is what they look like. Essentially, what we're looking at, the output is the coefficient. And put very simply, and I apologize to any health economists in the room, if the coefficient is above 0, people want that in their service. If it's below 0, people don't want it. And the first thing to highlight is the constant for pharmacogenetic testing. So the average uptake of this service is extremely high. people in general like the concept of pharmacogenetic testing, and this is backed up by work we've published with, again, Emma McGavin at QMUL in partnership with GEL, which was a survey, so a different methodology, understanding the UK population acceptance of pharmacogenetic testing. And around 90% of individuals said they would have a pharmacogenetic test. So there's broad acceptability. Now, with these coefficients, thankfully, what we're able to do is express them graphically. And so if we were to try to develop a pharmacogenetic testing service using current infrastructure, so doing blood testing, not making data available to the patient, and not making it available longitudinally, the uptake's really poor. It's around 50%. But by optimizing that service, by saying, well, we will use non-invasive sampling approaches, you can access your own data, and we're going to make that data available longitudinally, that uptake goes well above 95%. So critically, you can design your service in a way that people want to use. Now, one of the criticisms of discrete choice experiments is that people do them, and then nothing really happens with them. It's a nice paper. But we were able, because we did this at the beginning of our program, we were able to use this information to inform the progress study, which I'm going to talk about in just a second. So as part of this design, we had an asynchronous recruitment method, so with non-invasive sampling. The data was embedded within the electronic healthcare record, so it could be used longitudinally, and we made data available to the patients within the study protocol. And also, another output, if you want to play and make your own pharmacogenomics service, all that data has been uploaded to a website and an app, so you can see how making those different choices impacts on uptake, and who wouldn't want to do that? So there you go. So all that informed the piece of work that we're undertaking at the moment, the progress study. And we've explicitly designed this study to focus on that final mile, as we heard about this morning, how we move from insights to action, how you develop the infrastructure and the technology to ensure that data is available in that clinically relevant format and a clinically relevant time frame. The study is undergoing at the moment. I'm presenting an interim analysis here. The way the study works is patient would attend their GP practice, and they're considered for one of these index medicines, so commonly prescribed medicines, antidepressants, pain relief, PPIs, and statins, and there's a conversation between the GP and the patient. They say, we have a study ongoing at the moment. We can use genetics to potentially choose the most appropriate medicine for you. Would you be interested? If they are, they're handed a study pack. They go home. They're able to consent completely asynchronously, so they're able to do that online. They complete a saliva sample, and they can post that in any postbox around the country. The idea is that then that reaches our laboratory a few days later, and because we knew we needed to get these results back as quickly as possible, we've optimized our laboratory process as much as we possibly could. We use a SNP-based genotyping approach with something called digital droplet PCR to look for copy number variation, and we're focusing on 4 key study genes based on the medicines that we're looking at. So this is really narrow at the moment. CYP2C19, CYP2D6, SLC01B1, and CYP2C9. We know that SNP-based genotyping is imperfect. It cannot resolve all of the complex regions that we might need to for all of our patients. And so we have a parallel program of work for those individuals that were unable to resolve some of those complex regions, looking at long-read sequencing technology, working with PacBio and Nanopore, and comparing those approaches. We aimed for the SNP-based genotyping for an end-to-end time of less than 10 days. And we've not picked that randomly. That's based on the discrete choice experiment work that I showed you just earlier. So the samples reach the lab. They're ran by our lab team 3 times a week. And then that data, and this is the core of what we're doing, is uploaded into a cloud-based resource. And the reason we've created this is so we are agnostic of our technology provider. So whether you are using a Gina, or you might be using Illumina or Thermo Fisher, providing you can move your data into a data standard, which we have developed and published, you can see that via this link, using a standard called OpenEHR, you can use any of those technology providers. And then on the other side, we are also agnostic of the electronic healthcare record provider. And this is absolutely critical in a system like the NHS, where we have a myriad of EHR providers. Different hospitals use different systems, different GP practices use different systems. If we had an approach where we were just moving that data directly into the EHR, you just create more silos. This approach, a GP would go and prescribe a medicine. if that patient's had pharmacogenetic testing, there is a handshake with our cloud-based resource via an API, and there is a data packet pushed out into the EHR with a flag if there is guidance to be issued using an approach we call CDS hooks. This is what the data, or this is what the flags might look like in the system. This is a kind of early template. This patient has been prescribed codeine, but they are a poor metabolizer. There's a handshake between the EHR, between our system, and you get a high severity warning. This patient is a poor metabolizer for CYP2D6. They should not be prescribed codeine, and an alternative should be considered. Now, across the study, we had 3 types of flags. No impact, so a green recommendation. Clinically relevant, where there is a heightened risk of poor response or adverse drug reactions, but there's no explicit prescribing guidance issued. And then clinically actionable, where there is clear evidence-based guidance that you should choose an alternative medicine or you should choose an alternative dose. So this data that I'm presenting here is based on the first 500 patients that were recruited, with 2 patients withdraw from the study. So the data you're going to see here is based on 498 individuals. So we have 20 sites across the country. We started in Manchester, which is why you've got this little cluster around there, but we have a site in each of the GLH, GMSA regions around England. We were able to turn the results around in 9 days, and that is split across our time from review to consent, the sample transit, the receipt to extraction, and then extraction to results. And because we've optimized that resulting process, there's very little bioinformatic input into that. It's dropping the output file into our clinical decision support system. We saw that pharmacogenetic variation in this initial cohort was incredibly common across the cohort, which is not surprising because we know it is common in the population. That non-wild type variation is split across our 4 study genes, and if you look at individuals, if they carried any pharmacogenetic variation, you see across those 4 study genes, and if you look at the wider pharmacogenetic panel, that over 90% of individuals carried a pharmacogenetic variation, a variant which could be potentially of interest. Now that's all very good and well, showing that this is common in the population, but is that relevant to the medicine that they have been prescribed? And we found that it was. So the vast majority of patients were recruited based on antidepressant or receiving a statin, and we saw that around 50% of participants either had a yellow flag or critically a red flag recommendation. And 1 in 8 individuals in this interim analysis had a recommendation surfaced within their EHR that they should be prescribed an alternative medicine or a change to their dose. So meaningful guidance is being issued in this cohort. And that is derived mostly from patients receiving antidepressants, but we see a host of clinically relevant recommendations across our cohort who've received statins, opioids, and PPIs as well. So we know this variation is very common. We know it's related to the medicines people are exposed to, but actually, are we able to change behavior in the clinical setting with the information that we're providing? All we're doing is moving this information, moving these recommendations out into the EHR, and we have no way of knowing exactly what people are going to do with that. What we've seen from going back and looking at those records a month later is that this is driving behavior change in general practice. And so depending on the flag recommendation that you receive, you see a significant difference in whether you have a prescribing adjustment or not. And so if you had a red flag recommendation, you were far more likely to have a prescribing adjustment. And you might say, well, that seems very obvious because you told people to change the medicine. But again, this is not part of the study protocol. We're generating that evidence, moving it out into the EHR, and then it's up to GPs what they do with that information. So we are able to change behavior, and you can look at that as an odds ratio. The likelihood of you having a prescribing change based on a red flag recommendation is significantly higher than an orange, and an orange than a green. But we know adherence is not perfect, which is unsurprising given this is a very real-world, pragmatic implementation. And we saw 12 individuals who had a red flag recommendation saying they should have an alternative medicine or a change in their dose where that wasn't followed. And there's a myriad of reasons for that. 1 patient declined the alternative medicine that was being recommended, and 5, there was delays due to a requirement for repeated samples. And 6, it was unexplained. That was where originally we were using an external portal. And we sense that if it takes too long to get that data back into the clinical setting, the likelihood of those recommendations being followed is extremely low. So again, emphasizing the need for us to optimize those end-to-end pathways, or critically, having that data already embedded within the healthcare record when the patients come to clinic. What we're doing here is a reactive with reuse approach, but actually if we had a fully preemptive model, that data is already there. So in this interim analysis, we saw that 25% of individuals had a prescribing adjustment based on those red or orange flag recommendations. And what is exciting within this piece of work that we've been able to undertake is that we think the data model and the approaches we've developed provides a scalable and interoperable model for implementation of pharmacogenomics, but genomics more generally. This doesn't have to be pharmacogenomics. In theory, you could do this for polygenic risk scoring if you had the language to work with. It provides a scalable solution for this in the NHS. And so we've seen over 1,000 API calls so far, just in the small amount of patients we've recruited, and we've seen 224 interruptive alerts. Because this is interoperable, we also have a parallel program implementing this at our hospital in Manchester, and we have an Epic EHR, and we've seen over 5,000 calls to the service during our program of implementation so far. So, in conclusion, we believe that pharmacogenomic guided prescribing will become an increasingly relevant and routine part of clinical care in the NHS. Service design is absolutely critical. If you design a service that people do not want to use, or you just try to return a PDF to someone for this type of intervention, it will not be used, certainly not beyond that initial index prescription. We've seen that we are able to drive action, drive behavior change from this type of intervention, but we know we can do better, we know we can make those services more impactful, and we think that the only way to deliver this is via this cloud-based infrastructure, pushing that data out into the electronic healthcare record system. We've been able to show that this variation is common, it's related to medicines that people are on, and that we're able to drive behavior change. But the next step is clearly demonstrating that this is leading to meaningful health gains for individuals and for the population. And to do this, we need to leverage patient-reported outcome measures and really utilize that routinely collected healthcare data. And we're really excited about doing this over the next few years. So this has been a huge collaboration between a really great team in Manchester, around the UK and internationally. Thanks very much, and happy to answer any questions.